Okay. I can see in the last session we have covered genitourinary section, and today we have to discuss the questions from the genitourinary section as well as we have to discuss the mock. So now, Gauri, Kashish, and Shefali, have you attempted any questions from the mock sessions or mocks? Did you have any question, any doubts?
Ma'am, actually, still I have not attempted the mock questions.
What about the genitourinary question set?
Yeah, that I tried and I was able to solve, but I have not completely solved that.
Okay. Any question in that one?
No, ma'am.
Okay. Gauri, what about you and Shefali?
Ma'am,
For
I have
now,
not
no.
solved
I'm
each and
going
every
on.
question, but the questions that I've solved, I have no problem in them.
Perfect. Gauri, what about you?
I'm going on with the questions.
Any questions till now? Anything which you want to ask?
No, ma'am, for now.
Perfect. So I'm considering you guys are clear till now. So let's move to the other session. So let me remind what all things we have completed till now. Okay. So we have already covered the chapter number 1, chapter number 2, 3, 4, 5. Have we discussed the or started the chapter number 6, nervous system, or we have to start it? Anyone? Did we have already covered the chapter number 6, or is there anything pending? I have to see the question which I have sent. Okay. So it is not started yet. So today we have to start from the nervous system. Okay. So our 6 series starts from here, from the endocrine system. Our 6 series codes represent the conditions or the procedures performed on the endocrine system as well as on the nervous system. So, can any one of you tell me what all organs we have in the endocrine system? What all organs we have in the endocrine system? What procedures we can expect in this section?
Thyroid.
Yes, thyroid gland, adrenal gland, pineal gland. So any procedure performed on the endocrine gland, for that we are going to get the codes from the 6 series. So the first is thyroid, then we have a parathyroid, thymus gland, adrenal, pancreas, carotid body. So the procedure performed on these sections, we are going to get the codes from 6 series. So let's start with the thyroid gland first. So in the thyroid gland, we have a codes for the incision, followed by the excision, then other repairs, and the other procedures. So in the incision, we just have the one code, that is incision and drainage of the thyroglossal duct cyst. So this cyst is formed from a duct that has not completely closed or disappeared by the time of thyroid gland has moved into the permanent position in the neck. So whenever there is a embryonic development, then the cyst has been performed and not completely closed. So it's a thyroglossal duct cyst. So whenever doctor is just doing incision there to drain the fluid from that cyst, then we are going to use the code 6 4 times zeros. Then we have our next section, excision. In the excision, our majority of code describes the procedures, thyroid removal, or lobectomy. So the first code is biopsy of thyroid. Approach is needle. This is not the open. This is open percutaneous core needle approach. It's not an open. And whenever you're going to build a biopsy, and if you see that's a FNA procedure, then for FNA we have to code the FNA only. One series code irrespective of the location. So whenever it's an FNA, whether it is performed on the kidney, nervous system, glands, anywhere, if it is related to the FNA, we are going to use a code from one series only. Then we have a biopsy thyroid. This is for percutaneous core needle. The difference between FNA and core needle is size of needle. In the core needle, we are getting the tissue little thicker compared to the FNA. And if it is a biopsy is performed under the imaging guidance, we have to code the imaging guidance separately. Next, we have excision of cyst. So whenever doctor is removing the cyst or adenoma is tissue, removing the abnormal growth tissue from the thyroid or the isthmus, then we are going to use 60020. Let me pull the image for the thyroid gland quickly to show you the lobes. So our codes are based on the thyroid removal and lobectomy. Lobectomy describes the removal of single lobe of the thyroid. We have a two lobes, right lobe as well as the left thyroid lobe, and in between we have this isthmus. So whenever you have a lobectomy in your procedure description, that means doctor is removing only one lobe, either right lobe or the left lobe. If you have a code which says partial lobectomy, that means partial lobe has been removed. Partial lobe. So we have a code for the complete thyroidectomy. We have to build complete thyroidectomy or total thyroidectomy only if the complete thyroid gland has been removed. If only lobe has been removed, we have to use a code for the lobectomy. So these are here code. So the first one is thyroid partial thyroid lobectomy means half lobe has been removed. It's an unilateral, and 60212 with the contralateral. Contralateral means right plus left. Subtotal means more than 80%. So if the lobe has been removed more than 80%, we are going to consider it as a subtotal. Then we have here total thyroid lobectomy. Total thyroid lobectomy means the complete thyroid lobe has been removed. If the complete thyroid lobe has been removed, we are going to consider it as a total left thyroid lobectomy. Next we have same code, subtotal lobectomy. That means more than 80% of the contralateral lobe has been removed. And next we have complete thyroidectomy, 60240. These are for the complete thyroidectomy, total or complete. Subtotal means more than 80%. This one 60252 need to be used when the subtotal malignancy has been removed. Thyroid had been removed through the neck dissection. So approach is neck. From neck, doctor reached to the thyroid lobe, thyroid, and then he removed the thyroid completely. Then we have 60250 with the radical neck dissection. Radical neck dissection means in conjunction with the neck, radically lymph nodes has been removed. So that is radical neck dissection. Then we have thyroidectomy, removal of remaining thyroid tissue. That this is in secondary thyroidectomy. It has been secondary means once primary thyroidectomy already has been performed. Now patient is coming to remove the thyroid completely. So there is a previous removal of portion of thyroid. Let's say previous patient had the lobectomy and now coming for complete thyroidectomy. So today you will going to use a code from series 60260. Next we have 60270. Thyroidectomy including substernal thyroid and the sternal stem. So approach has been used through the sternal area or sternum area. Here approach is cervical approach. Next we have a code for the thyroglossal duct excision. This is first excision. Cyst or sinus means abnormal opening is there. If it is a first time excision, we are going to use 281. If it is in secondary excision, we are going to use a code from series 60281. So next we have other glands, that is parathyroid, thymus, adrenal gland, pancreas. So in this, we just have a normal excision section. We does not have other section in this. So the first is parathyroidectomy for the exploration of parathyroid. So these are very word to word codes. I'm moving to the next section. Okay. So it does not have any question right now. So I'm moving further. Next, we have the nervous system. So after the procedure, normal procedures, we have the nervous system. Nervous system.
7 days तक देखोगे तो 300 डॉट
Okay.
7 days तक streak 7 days
So our nervous system is divided into the three primary sections. So in nervous system, we are getting the codes for the procedure performed on the skull, meninges, and brain. Skull is cranium bone, covering of the brain, as well as any procedure performed on the brain. So we are getting the codes from series 6100 to 62258 if any procedure performed on skull, meninges, and brain. Next section we have spine and spinal cord. So any procedure performed on spine and spinal cord, we have to use a code 62263 to 63746. And in the last, we have our extracranial nerves, peripheral nerves, and autonomic nervous system. So any procedure performed on the extracranial nerves, peripheral nerves, and autonomic nerves, then we are going to use a code from series 644. And we have multiple procedures here. We don't have just excision or incision like we have in other sections. So even in the skull, meninges, and brain, first section we have injection, followed by the twistal. Twistal approach is the procedure which will tell us that how to approach the brain. And then we have a surgery of skull bases. These surgeries of skull bases are corely based on the approach, whether we are doing the anterior approach or the middle cranial fossa approach or the posterior cranial fossa approach, followed by the endovascular therapy and so on. So we will start with the skull procedures, skull, meninges, and brain. So first we will see the anatomy. I'm mentioning skull bones. So there are total 22 bones in the skull, but we have to review only the cranial bones. That is 8 cranial bones. So total we have 8 cranial bones. Mm, So these temporal bones, these are the temporal bones, ethmoid, frontal, and parietal, and this occipital. So one occipital, that is backside, parietal middle, frontal front side of the skull, temporal backside of the ear, and the ethmoid. So these bones are comes under the cranial bones. So any procedure performed on the cranium bone, for that we have to use a code from series 6 series. Next we have meninges. So meninges are the covering of the brain. Let me hold the image for this. Yeah, this is perfect. So these are the meninges. So the outermost layer from the skull side. So the outermost layer is known as dura mater. Middle layer arachnoid. Innermost layer pia mater. So the first layer at the brain side, that is pia mater. Then we have arachnoid, and then we have outermost layer that of the meninges, that is dura mater. So meninges, we have 3 meninges, and brain lobes. Let me see the brain lobes for quickly. Lobes. So these are the 4 main lobes of the brain. Frontal lobe, this is the front side of the skull. Parietal, temporal, and occipital. In between the occipital and the cerebellum, we have a one line, that is tentorium cerebelli. Here we have a tentorium cerebelli. So any procedure performed at the upside, that is supratentorium. At the bottom, that is inferior tentorium. So now let's start with the procedures. So the first section we have injection, drainage, or aspiration. As we can see with the name, in this, doctor is injecting something in the patient's body, doing any drainage or aspirations from the patient's body. And these codes are need to be used if the injection, aspiration, and the drainage are done at the skull or meninges area. So the first we have subdural tap to the fontanelle or suture implant. So these procedure doctor will perform for the hydrocephalus. Whenever patient have the hydrocephalus, a small minor hydrocephalus, and doctor is just removing the fluid to the subdural tap through the fontanella suture. Suture, let me show you sutures. Suture is a joining of the two lobes. So whenever doctor is just removing the fluid from that area, then we are going to use 6100 if it is doing primary first time. And if it is in subsequent types, we are going to use a code 61001. Then we have a question for the codes for the ventricular puncture. Ventricular puncture means doctor need to do the puncture in the ventricles of the brain where the opening is already made. So patient already had the previous burr hole. So burr hole is opening in the cranium. Patient already had the opening in the cranium. And now just doctor is doing the ventricular puncture to implant the ventricular catheter so that he can implant the ventricular catheter. So we are going to use 61020. If doctor need to make the opening in the cranium, then we have to build the opening separately. But if the opening is already there, then we have to use 61020. Next we have 61026, injection of medication or other substance. So with the ventricular puncture or the catheter placement, if the doctor is injecting any medication and any other substance to treat that area, then we have to use 61026. Then we have 61050 and 55. Here doctor is doing the puncture at the cervical level. So if doctor is just doing the puncture at the lateral cervical or cisternal area and inserting any medicines, then we have to use 61050 and 61055. So cisternal and lateral cervical puncture are similar to the lumbar puncture. Doctor need to do that to gain the access to reach the cerebromedullary cistern. That is a subarachnoid cistern. So if the doctor need to reach there, doctor need to do the puncture at the cisternal or the cervical area. It's the same as an lumbar one, and these procedure needs to be done to reach out the subarachnoid area of the brain cavity. Then we have puncture and shunt tubing. Shunt tubing means so doctor need to place the shunt or any pump for the drainage purpose, for the aspiration purpose. So if the doctor is, let's say, um, placing a catheter in the ventricular canal, and then at the bottom, at the abdominal cavity, he is placing a pump for the medication purpose, then we have to use 61070. If while doing the puncture, doctor need to use the radiological supervision, we have to code 75809 separately in conjunction with the 61070. Next we have twisted burr holes or trephines. Twisted burr hole or trephine, cranectomy and craniectomy. These are the tools the doctor need to use to create the opening in the cranium areas. So the first code is 61105. 61105. So all these codes needs to be used if the doctor is making an access or making an approach to brain. So these are the tools only. 1, 2, 3 tools. Let me show you the picture of these tools. So the drill is a type of twist. Okay. Twist drill, craniotomy. Craniotomy. Sternotomy. Images. So this is our twist drill tool. So this is a machine, and with this tool, doctor need to do the opening in the cranium. Okay, so these are the tools. So trephine is a little bit thick tool with the twist drill. Okay. Next, we have twist drill holes for the subdural intracerebral ventricular puncture for the ventricular catheter. So in 61007, doctor is just doing the holes as well as implanting the ventricular catheter. In the previous code, this is ventricular puncture. Here, patient already had the opening and then doctor is placing a ventricular catheter or implanting the ventricular catheter. But in this case, 61107, doctor is doing the hole and then implanting the catheter. So in both cases, provider is implanting the ventricular catheter, but in one, opening is already there and in the other, opening is not made yet. Then we have burr holes for the ventricular puncture. With the burr hole, doctor is not making any implanting any catheter. He is just adding the contrast media or any dye or radioactive material. And then we have burr. So these are the burr hole with the trephine. Trephine is the name of tool only. So we have a code. These codes are there to create the opening in the cranium bones or in the skulls. Next we have cranectomy and craniectomy. Okay. So the next section is cranectomy and craniotomy. So cranectomy and craniotomy is more extensive than twist drill holes or the burr holes which we are doing through the trephine. So these are more extensive compared to the previous opening codes, twist drill and the burr holes, because in the cranectomy and the craniotomy opening is larger. So the craniotomy is a bony opening and where doctor need to make the cut into the skull. So in the cranectomy and the craniotomy, doctor is making the incision and doing the cut. So if the doctor is making a cut and removing a section of the skull, then we are going to pick a code from the cranectomy and the craniotomy section. So whenever doctor is doing any incision, removing the section of the skull and then reaching out to the brain, so that will be the cranectomy and craniotomy. So whenever you are going to build a code for the cranectomy and the craniotomy, you need the reason of the surgery, that why doctor is doing cranectomy and craniotomy. It is due to the exploratory purpose or the evacuation of hematoma or the evacuation of abscess or removal of tumor, as well as you have to see the approach. So the first part you have to refer the type of disease, that why the doctor is doing this surgery, and the second approach or second point is you have to see the surgical approach. So what is the surgical approach to remove the portion of the skull? And then here we do have a code for the infratentorial and the supratentorial. Infratentorial as well as supratentorial. The difference between the infratentorial and the supratentorial is if the procedure is above the tentorium, then it's a supratentorium, and if it is below the tentorium, that is infratentorial. So basically, tentorium cerebelli is a tent of the dura mater which separates the cerebellum from the occipital lobe. So let me show you the picture of the tentorial. So this is the tentorium. Any procedure performed at this area, this is supratentorium, and if any procedure performed at cerebellum, that is tentorium. So this is a layer between the occipital or the parietal lobe and one cerebellum and cerebrum. We do have a course for the extradural. Extradural means outside the dura mater. So that outside the dura mater known as extradural. So first you have to see the surgery and the reason of surgery, and then you have to see the approach to identify the correct code for the cranectomy. So first one is exploratory, second one is evacuation of hematoma. Then we have evacuation of hematoma for infratentorial area, that is cerebellum. This one is for abscess. This was is for intraparenchymal hematoma without lobectomy. So again, you have to see the disease first, and then based on the approach, you have to pick the code. Send one question for the cranectomy section, then we will move further. Okay, I just received the answer from one person. What about other? We're still doing, or shall we start doing it together? Perfect. Okay, let's get started. Now let's do this together. So now question, patient had a resection of the right temporal lobe tumor, and now coming for the supratentorial tumor. So patient have the supratentorium tumor at the cerebrum area. Then previous craniotomy hardware was removed. So patient had the craniotomy earlier, that has been removed, and some burr hole were drilled, and the previous craniotomy was reopened. There were burr hole earlier, that has been drilled and it has been reopened. Then imaging guidance is also used to identify the area of the tumor at the anterior edge of the temporal lobe. The tumor was resected and suctioned, and the frozen section specimen was sent. We use the operating microscope also, and then using a suction technique, bipolar cautery that has been cauterized after careful dissection and the removal of the tumor. Hemostasis was obtained and the bone flap was replaced using the synthesis cranial plating system. So the part which has been removed, that has been artificially replaced with the plating system, and two central tack-ups were applied. Specimen at the margins of the tumor were sent what course should be. So whenever we have to code a for craniotomy, first thing we have to see the disease, and the second thing we have to see the approach. So the disease here we have tumor, and the approach is supratentorium because patient had the condition at the supratentorium. Now let's see the options. So first we have 61140, that is little odd, so I'm reviewing 61140 first, then we will move to the 615 series. So 615 series is for the craniotomy and 61140 is for the burr holes only. This we have to build when the doctor need to do the biopsy of the brain for the intracranial lesion. In our case, doctor is not just doing the biopsy, he is removing the tumor. So we are not going to use 61140 because doctor is not doing the biopsy. Now we are left with option A, B, and C. So 510, 518, and 500. So 61500 is with the excision of tumor or other bone lesion, skull, that is 61500, 61510, and 518. 518 is cranectomy for the excision of brain tumor. This is infratentorial. So as this is an infratentorial, we have to rule this out. We are not going to use the 61518. Left with option 61510. So 615 supratentorial craniotomy, and the bone flap has been used. So we are going to, this is for brain tumor. Disease is a brain tumor. So answer should be A only. So the answer should be A. Here, answer should be A here. Whenever you are going to perform any cranium procedure or the skull procedure, you have to see the disease followed by the approach. Clear? Any questions in this question? Any doubt?
No, ma'am.
Okay. So the next thing we have surgery of skull base. To clearly or to correctly build the surgery of the skull base, we have to follow the three things. First, we have to see the approach, that how the procedure has been performed and how the brain has been accessed, or how we receive the access to the lesion. So first we have to see the approach. Then we have to see the definitive procedure. Excision, biopsy, ablation, what type of definitive procedure doctor is doing. And the third is repair and reconstructive procedure. Repair and reconstruction means after making the approach and after the procedure, how doctor is repairing that area or how the doctor is reconstructing that area. So the third part is how the doctor is repairing that area. Are all surgery codes, surgery of skull base codes are based on these three approach: anterior, middle, and the posterior cranial fossa. So our all codes are based on the three approaches, that is anterior, middle, and the posterior. Approach codes are from this series as well as the definitive procedures are from these three approaches only. And when you are going to build the surgery of skull base, you have to make sure your approach to access that area as well as your definitive procedure should be from same approach. You cannot use a different approach, one for the definitive and one to reach the area. Let me show you this. These are the approach procedures. In the approach procedure, we have anterior cranial, posterior cranial, and earlier we have the middle cranial fossa. And definitive procedures also, we have the same location, anterior cranial, middle cranial. So whenever you are going to build any procedure from the anterior approach, you have to make sure that under the definitive section, you are going to use the same approach or the same area. So if you are using the reaching the access or making the access to the posterior canal, then definitive procedure should be from posterior canal itself, posterior cranial fossa itself. So whenever there is a surgery of skull base, you have to make sure that approach of the definitive area as well as normal approach should be match in all the cases. Let me see if we have any question here and I can send that to you. Just wait a second. Okay, now let's discuss this question together. So in our case, patient is having a headache, and during the angiogram, doctor is able to see that there is a carotid aneurysm, 13 mm carotid aneurysm, which cannot be coiled. So we have to do the clipping. So doctor makes the approach and cut the skull to expose the brain. And then middle cerebral artery and the both branches were identified. Clip has been placed into the intracranial aneurysm. And after placing the clip, aneurysm has been resolved. So now we have to tell them the code. So the difference between 61700 and 61701. Okay. 705 is a surgery for aneurysm, vascular malformation, or carotid cavernous fistula by intracranial and cervical and occlusion of carotid artery. However, in our case, doctor is not doing anything occlusion on the carotid artery. There is a intracranial aneurysm, but the doctor is not doing anything on the carotid artery. So we cannot use this code at all. As well as 61703 is for the cervical approach. He does not have the cervical approach. Doctor is making the incision into the skull. So it's not the cervical approach. That is 61703 is also has been ruled out. And the last we have 61700. So the 61700 is correct because that's an intracranial approach, and patient just have the simple intracranial aneurysm, and doctor need to do the clipping only. Doctor is not doing anything else apart from the clipping. He is just placing the clip on the intracranial aneurysm. So the correct answer should be 61700. That is option number B instead of the option number C. Zamil, can you explain that why you choose the option number C? Why you feel that 61705 should be the correct code?
Ma'am, it's mentioned here surgery of aneurysm. It's done by
It,
intracranial and carotid artery.
this is also a surgery of intracranial aneurysm, as well as the first code we have here. That is also a surgery of simple intracranial aneurysm. So in all cases, the doctor is doing the surgery of the intracranial aneurysm itself. Okay, you have to use 61703 or 705 only if it is a cervical approach. If it's a cervical, then you have to use 61703. If it is an intracranial approach or the doctor need to reach there by the cervical occlusion and to cervical occlusion of the carotid artery, then we have to use 61705. Clear, Zamir?
Yes, ma'am.
Ma'am,
So
I
the
have
answer
a
should be. Mhm.
can you please differentiate between complex and simple surgery 61697 and 61700?
Okay. Complex intracranial aneurysm and the simple. This is based on the size of aneurysm. If the size is larger than 15 mm, then we are going to consider it as a complex. If it is size is less than 15 mm, then we are going to consider it as a simple. So the difference between the larger complex and simple is just in size. If it is more than 15 mm, we are going to consider it as a complex. If it is less than 15 mm, this is for aneurysm only, okay? So if it is less than 15 mm, then it should be the simple. Clear?
Okay, thank you. Yes.
Okay. Now let's move further. So after the surgery of skull base, we have the codes for the endovascular therapies. So endovascular therapy is little less invasive procedures compared to the open vascular procedure. So these are the little less invasive because here we have to use the endovascular endoscopies, and these procedures are performed via endoscopy. So in the vascular system, doctor is inserting a wire or fiber optic tube to perform that procedure. So these procedures are described by 61623 to 61651. Let me pull these code for you. Here we go. 61623 to 61651. In these codes, selective catheterization is included. So in all these codes, selective catheterization is included of the target vessel. Hence, we should not bill that separately, as well as radiological supervision and interpretation is included. Radiological supervision and interpretation is also included. That does not need to be billed separately. So in these procedures, we have the selective catheterization included in this code as well as the radiological supervision and interpretation included. Rest all these codes are based on the procedure performed. Like earlier we have the selective catheterization, here we have the balloon angioplasty and the intravascular stent placement. This is a balloon dilation. Earlier we have the balloon occlusion. This is a balloon dilation. So these codes vary based on the procedure, but the catheterization and the radiological supervision is included until unless otherwise mentioned. Next we have okay. Next we have a code for the surgery for aneurysm, arteriovenous malformation, or vascular disease. Just give me a second. Let me reopen this manual so that all these things can be rubbed out. So now we will start from the surgery for aneurysm, arteriovenous malformation, or vascular disease. So these codes are divided into the four categories. Four categories. Four categories. And these categories are divided based on the type of condition. So the first category we have 6802 61692. We have to pick the code from this section whenever patient have the arteriovenous malformation. This is when arteries and veins has been fused abnormally with each other and they have created the fistula and now they are bypassing the capillaries. So this is the arteriovenous malformation. So if there is a arteriovenous malformation and doctor is repairing that arteriovenous malformation, then we have to use a code from series 61680 to 61692 based on the approach. So the first one is simple, then we have a code for the complex. And again, this is an arteriovenous malformation, not the aneurysm. So we have a different codes for the simple and complex. And here we will decide the difference between the simple and complex based on the approach. If it is in supra, how the doctor is reaching, or what is how we are able to access that lesion and how difficult to repair that area. Based on that, we will decide the difference between the simple and complex. Next section, we have the intracranial aneurysm. Okay. So the intracranial aneurysms, you already know what the intracranial aneurysm means, bellowing of that arteries. So whenever patient having a intracranial aneurysm and we have the bulging or the abnormal dilation which cause the walls of being weak, walls of arteries being weak. So in these we have to code the user code from section 61697 to 61703. These codes are also based on the simple and the complex. So according to the CPT guideline, complex aneurysm is larger than 15 mm. So if the aneurysm is larger than 15 mm, then we are going to consider it as a complex. If it is less than 15 mm, then we are going to consider it as a simple. So all these codes are based on the simple complex as well as approach to treat the aneurysm. And third category we have from series 61705 to 61710. This will describe other techniques and approach to repair the intracranial abnormalities. Maybe the combined approach has been used through the neck and skull, or surgeon interrupts the blood flow to the abnormality in the both direction. Then we have to use the 61705 because the doctor is creating the fistula so that blood can be distributed in the both directions. Or maybe doctor is using a intracranial electrothrombosis cautery to treat the lesion or to destruct the lesion. So intracranial electrothrombosis. And the last we have intraarterial embolization. So this is an injection procedure, balloon catheter, and we have the embolization also inside the intraarterial. Doctor is doing the embolization. So these codes are the other techniques to repair the aneurysm or the intracranial abnormalities. The last code we have 61711, that is anastomosis, arterial, extracranial, intracranial. This describes the joining of arteries to bypass an aneurysm or other defect. So if there is any other defect, doctor need to bypass that and removing that blood, bypass the blood supply, and just doctor is doing the anastomosis. Anastomosis means joining two arteries together. So in that case, we have to use 61711. And if the surgical microscope has been used for the microsurgical procedure, then we can use the 6990. If it is used for the visualization only, then we should not use 6990. Then we have a stereotaxis. So stereotaxic taxis or stereotactic radiosurgery. The stereotactic technique are the minimally invasive form of surgical intervention. In this, doctor need to use three-dimension coordinates so that he can locate the small target inside the patient's body, and he can perform the ablation or any surgery which he wants to perform at the lesion. So stereotactic means 3D. So whenever there is a 3D technique has been used to perform the procedure, in that case, they have to use 61715 series. So in this 3D, we have a different techniques. This was MRI technique. This is computer assisted techniques. So all these technique needs to be used to locate the lesion. Okay. Next we have neurostimulator. Neurostimulator. Okay. Next we have neurostimulator or intracranial neurostimulator. So the placement of intracranial neurostimulator we have to build with these series, with the 61850 to 61680. And programming or reprogramming needs to be built by the 9 series. So we have to use these series 95970, 95976 when the doctor is doing the programming of the previously placed neurostimulator. So if the neurostimulator is previously placed, doctor is just doing the programming of that neurostimulator. Then we have to use a code from series 9. If doctor is placing the intracranial neurostimulator. Then we have to use a code from series 61850 to 61888. So neurostimulator is a pulse generator system which needs to be implanted surgically, like a pacemaker. We have to implant it surgically. So it will deliver intermittent electrical pulses to the nerves or the brains, so that patient will not get the seizure activity again and again. And not just this seizure, that will treat the Parkinson disease, peripheral neuropathy, or any other nervous system disease. So in this procedure, we need to do the burr hole first. We have to do the craniotomy or the craniotomy, and then we have to place the stimulator intracranially. So then we have to place the neurostimulator into the brain. Cranectomy and craniotomy are included in the codes. So we have to pick the code based on the type of the approach. Then we have neuroendoscopy. Neuroendoscopy. So neuroendoscopy is a procedure performed by the. So basically, this is a less invasive compared to the incisional procedure on the nerves or neurons. The code descriptors are very straightforward, and we have a CPT parenthetical guidelines here also, so you have to follow that guidelines. And the CPTs are straightforward, so you don't need to. We does not have any specific guideline in the neuroendoscopy. One thing we have to make sure that we should not report an endoscopy code in addition to the identical open procedure. Let's say if the doctor is doing the intracranial dissection, additions, fenestration, so we cannot bill this one with the normal code with the open approach. So we have to bill either the endoscopy procedure or the open procedure. Next section we have the CSF, cerebrospinal fluid. So the standard surgical treatment for the for the hydrocephalus. So for hydrocephalus, doctor needs to do the shunting. Hydrocephalus is an accumulation of cerebrospinal fluid. Whenever there is an accumulation of cerebrospinal fluid, then we have to do this shunting. This includes the placement of shunt, maybe the extracranial or maybe the intracranial, so that the CSF fluid can be diverted to the ventricles to the another body area, maybe the abdominal cavity, and from the abdominal cavity we can drain that fluid from the drain side. So the external intracranial shunt needs to be created with the ventriculocystostomy, that means creating an opening or creating a shunt area in the ventricle in the cisternal area. Then we have a code 62180, the first one. This is a technique where doctor is creating the communication between the lateral ventricles and the cisterna magna. So it's a lateral ventricles as well as cisterna magna. This procedure will remove the excess CSF fluids into the subarachnoid and through the abdominal cavity, and then two shunt has been connected, and then it has been laid closure. So this is the whole procedure we have here. So these all procedure are for the hydrocephalus only, and these are the different techniques to remove the fluid from or the cerebrospinal fluid from the ventricular cavity. Let me see if I have any questions. We will wait 2 more minutes, then we will discuss. Okay, now let's discuss this question together. So we have received the response from the Kashish, Jamil, and Gauri. Now let's see this question together. Okay, so I'm pulling the questions only, codes only. 6792. So 62192 and 622092 and 2220. In 92, doctor is creating a shunt, and in 22, doctor is creating an opening in the ventricle and the cisternal area. Now let's refer the question. So the neurosurgeon is placing the arterial shunt. So doctor is placing the shunt. An incision is made across the anterior border of the sternocleidomastoid muscle, jugular vein, and that has been isolated. And small opening made into the jugular vein, into the right atrium of the heart. The physician drills a burr hole, insert a proximal portion of the shunt toward the lateral ventricles. So the shunt has been placed into the lateral ventricle until the CSF flows through the shunt, and then distal end of the shunt is tunneled to the jugular vein subcutaneously, and then these two ends were connected and tested. So in our case, this needs to be used when the doctor is creating a shunt. But in our case, doctor is placing a shunt. Jamil, are you able to understand the difference between 62220 and 62192?
Yes, ma'am.
So why you picked the 92? Can you tell me the difference between 92 and 000? This one is between the subarachnoid, subdural, and peritoneal and pleural. And this one is to the ventricle, to the jugular or auricular. Okay? So in our case, doctor placed the shunt in the ventricular and joined to the jugular, and the end was jugular vein instead of the peritoneal and the pleural cavity. Clear,
Yes, ma'am.
Jamin? Okay. Okay. So after the cerebrospinal shunt placements, we have a code for the spine and the spinal cord. So in the spine and spinal cord, first section we have injection, drainage or aspiration. So in this section we have a extensive codes as well as number of parenthetical instruction. So we have to make sure that whenever we are going to use a code from this section, we have to read the parenthetical instruction to make sure we will build this correctly. So first let's start with the 6263 and 6264. This is a epidural lysis of spinal adhesion. Epidural lysis of spinal adhesion means the doctor is releasing the adhesions between the spines or epidural area. So in this, doctor insert a needle near the patient's tailbone and then catheter through that needle to inject the medicines into the adhesions. And then with the, because it's a percutaneous, not the incisional, not the open one. So this procedure is performed with the catheter or the needle. And after the medication has been inserted, that needle may be removed and then catheter may be stay there for the several days so that that can be treated for the multiple days. If it is more than 1 day, then we have to use 62263. If it is for 1 day only, then we have to use 62264. Next we have 62268. So 62268 is percutaneous aspiration. So in this, the doctor is removing the content of cyst or syrinx. Syrinx is a fistula or diseased area is known as a syrinx. So doctor is removing the aspiration, this aspirating the cyst or syrinx using a needle, and then the doctor is using the C-arm or the X-ray machine to verify the needle is correctly placed. If the needle is correctly placed, then we have to use the radiological supervision also if the radiological supervision is also used with that. Then we have another code from this section, spinal puncture or spinal tap. This one, spinal puncture, that is also known as spinal tap. So we have to use these code for spinal puncture whenever doctor is doing any lumbar puncture for the diagnostic purpose. For diagnostic means doctor is reviewing the TSF fluid to see if there is any conditions. So diagnostic means to see if there is any condition, and 62328 to see if there is a fluoroscopic or CT guidance. We do have a lumbar puncture code for the therapeutic. 62272 is for therapeutic and 70 for diagnostic purpose. Okay, let's move further. So after this, we have two, three, five, zero. Okay, next section we have the catheter implantation. So catheter implantation are code begin from pain pump. Okay, 62350 to 62370. These procedure is also known as pain pumps because we have to use these pumps for the pain management. Here the doctor is placing the pump so that this is an infusion pump. And with the infusion pump, catheter has been inserted so that medicine can be released on a particular time period and patient cannot feel the pain. So that's the only reason that is also known as the pain pumps. Okay. Next, the major thing we have implantation, laminectomy and laminotomy. Laminectomy and laminotomy. Laminectomy means excision of lamina, and laminotomy means hemilaminectomy. So whenever you see this word laminotomy, that means hemilaminectomy. That's a partial excision of the lamina. So these procedures are primarily done for the decompression procedures. So nerve decompression. So these procedures are usually performed for the nerve decompression, and we have to read the code descriptor very carefully to determine if there is any particular procedure related to that disease, as well as we have to see if the vasectomy and foraminotomy is also performed in conjunction with the laminectomy. So these procedures are grouped according to the location. So let me pull the locations. So you can see here, we have a separate code for the location, that is cervical, thoracic, lumbar, and sacrum. So these procedures are grouped according to the spinal region, and some procedures are based on the segment, whereas some procedures are based on the interspace. So you can see here, this code is based on the vertebral segment, and this code is based on the interspace. Interspace means this procedure can be performed between the lumbar 3 and lumbar 4 vertebra, whereas vertebral segment means this procedure performed on this segment, this vertebra. So let me see if I can find any particular question with the laminectomy and laminotomy so that you can understand the difference between these codes? Give me a second. Let me find if we have any question. Okay, very well done. So you find the correct code. So answer should be C only. So 63047 and 48. 63047, laminectomy, facetectomy, unilateral, bilateral. For the decompression, hysteresis, stenosis. And the patient have the stenosis. So we have the 47. And for each additional vertebral segment, we have to use 63048. Let's review the other codes also to make sure that we will not rule out any other code. 3030. Okay, so 3030 is for the herniated intravertebral disc. And 4242 is for the re-exploration. So we cannot use re-exploration. We cannot use the previous one. And 63017 is a totally different because it's a complete laminectomy. Okay, one more thing I have. So this is a complete laminectomy. And this one is also a complete laminectomy. Laminectomy means that complete lamina has been removed. But in our case, it's an hemilaminectomy. So we cannot use this option. So your C answer is incorrect because it's an complete. But in our case, doctor did the hemilaminectomy. So we cannot use C option. So our answer should be 63020 because here we have the hemilaminectomy. So 63030, then 63035 for each additional. So the answer should be D. Clear that why the answer should be D?
Yes, ma'am.
Okay. Let's move further. I'm skipping these decompression procedure, moving to the next part of the nervous system. So still we have a code for the laminectomy, so I'm skipping these all.
हेलो हाँ भैया कहाँ पे हो? एक मिनट बोलो ऊपर 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 देखो ऊपर देखो ऊपर
So these are the neurostimulator codes. I'm skipping these because these are the same as which we did in the brain procedures. I'm skipping these. Yeah, this should be the topic. So next topic is injection of anesthetic agent, that is also known as nerve block. So the nerve block's codes are reported according to the nerve or plexus that has been targeted. So we have the parenthetical notes which will tell us particular guidelines which we have to follow. So you have to refer these guidelines whenever you are doing the coding. These codes are based on the particular targeted nerves and the plexus from the top to bottom. So the first you will get the code for the face nerves, followed by the occipital nerves, then vagus nerve, then brachial, and then bottom chest nerves, and so on. So these codes are based from top to bottom, and we have the parenthetical notes which will tell us whether we can build the radiological supervision separately or not. So whenever you will see including imaging guidance as a part of a code descriptor, in that case you don't need to use the imaging guidance code separately because it is already included in this code. Next codes we have here 64483 series. These are the transforaminal epidural injection based on the level. So these codes are based on the level, and these are the transforaminal epidural injections. We do have a separate codes for the facet joint injection. These are the facet joint injection and the nerves innervating from the facet joint. This code is also based on the level. Level means for each level you have to build the code separately. So you have to build this code per level, and if the procedure is performed on a both side, right and left, then you have to use the modifier 50 to represent that this has been performed on the both side of the level. So it's say if the facet joint injection is performed at the T12 L1 and L1 L2 level. So we have to use 64490. This is for thoracic, and 64494 twice because L1, L2 and 2 T2. So three codes are there. So 9091. We cannot use 91. So we have to bill for each level separately. And if it has been performed bilateral, we have to use 50 modifier. Okay, move further. Okay, so the next main topic, chemodenervation. Chemodenervation means the doctor is inserting chemicals or the drugs directly into the muscles. So the chemodenervation of extremity codes 64622, 64644, 5 and 3. These chemodenervation codes are based on the muscles as well as extremity, muscles and extremity. So if it is a 1 to 4 muscle, you have to use a code from these two options. If it is in more than 4 muscles, you have to use a code from these two options. So let's say if the patient have the injection on the right leg, 5 muscle, and left leg, 3 muscle. So in that case, your primary code should be 64644 because it is 5 for more muscles. And you have to use add-on code 64643 to represent each additional extremity. So whenever there is a 5 muscles or more than 5 muscles, then you have to use a code for 5 or more muscle, and you can use additional 64643 as well as 64645 based on the additional muscles which has been injected. Clear? This chemodenervation part is clear to everyone?
Yes, ma'am.
Not okay. I have shared one question. Try to solve that question and tell me what all codes we have to append. Okay. Any
Ma'am,
other
do we
answers?
have to add the number of muscles also, like with addition?
No, we should not because this code is based on the extremity. And then further extremity is based on the number of muscles. So we don't need to add the muscles. We just need to see whether it's in more than 4 or less than 5, less than 4. So like in our case, so patient had the chemodenervation on the left. Okay, let me mention it here itself. Okay. So in our case, patient had the injection on the left leg, 4 muscle, then left arm, 3 muscle, right leg, 4 muscle, and right arm, 5 muscle. So whenever in your documentation patient had the chemodenervation on a one extremity with the muscles are more than 4 or 5, in that case your primary code should be 64644. You cannot use 64642 because 64642 is needs to be used when the highest muscle is 4 or less than 4. So in our case highest one was 5. Okay. So highest was 5. So we have to use 644. So let's say we have built right arm 64644. This is for right arm. Then we have for right leg. Right leg, there is a 5 muscles. So we have to use this code. So after the right leg, we have 4 and 3 muscles. So we will use this code for each additional extremity. For each extremity, we have to use this code. So there should be 64643 into 2 because there are 2 extremities where less than 4 muscles has been injected. Any question?
Clear, ma'am.
Okay, Zamil, is it clear to you also? Gauri, because we cannot use 64642 and 644 together. Either it should be the 64642 or either it should be the 64644. Also, we should not use the modifier 50 because we have to code for each extremity. So we will not use the modifier 50.
Okay, ma'am.
So that's it. Next topic is neuroplasty. We will start from the neuroplasty from the next session. So let's wrap up the session today. Thanks everyone. Thanks for your time. Also, one more thing. Please try to complete the mocks so that we will get the sufficient time to prepare for the examination. So try to attempt the mocks and revise anything if you want to revise and ask any question if you have any. Okay.
Yes, ma'am. Okay, ma'am.
Thanks everyone. Bye bye.
Thank you, ma'am.
Thank you, ma'am.